from you all. I have a special welcome to Dr. Anurag Agarwal, who is the co-moderator for this session. We have been having these online teaching classes for the postgraduates for last more than 2.5 years. In fact, post-COVID, we started these online classes, and they have been continuing. This is in support from the IIP Delhi, from ICH Institute of Child Health, and from the National Institute of Accredited Hospitals. So this Wednesday, we have a presentation from the Department of Pediatrics from one of the DNB trainees. Dr. Radhika is our third-year trainee. So she will be presenting a case. So let her first present the history, the physical examinations, and in between we can interrupt. So this is primarily meant for all the DNB residents, all postgraduate students of pediatrics, family medicines are welcome to attend this. So you can circulate this message to your other colleagues. Dr. Radhika, you can start. I'm sorry, I am not on my laptop. I'm doing it from my mobile. So, but just excuse me for that because my mobile is not, I can't connect Zoom from my laptop. Go ahead, Dr. Radhika.
Thank you, sir. Good evening, my seniors and my dear colleagues. Today we'll be presenting a case of an 8-year-old female child, date of birth 27th of March 2016, residing from Karnal, Haryana. The informant was the child's mother, who was a reliable informant. This 8-year-old female came with complaints of fever for the last 15 days and cough for 8 days. The child was apparently all right 15 days back when she developed fever, which was insidious in onset, high grade, recorded up to 104 degrees Fahrenheit. It was intermittent in nature. It was associated with chills. There was no diurnal variation, and it was spiking every 8 to 12 hourly. The child was active in between the fever spikes. The child also developed cough 8 days back, which was insidious in onset. It was a wet cough, but she could not produce the sputum. There was no diurnal variation or association with change in posture, and it was not associated with post-acid vomiting. Coming to the negative history, there was no history of weight loss or night sweats, lumps, headache, sore throat, earache or discharge, abdominal pain, loose stools or vomiting, unpasteurized milk intake, pets, travel, swelling on face or feet, chest pain, difficulty breathing, noisy breathing, chest tightness, cyanosis, or fast breathing. Coming to the past history, there is no history of previous similar episodes. There is no history of recurrent respiratory infections, and she's not a known asthmatic. This is the 3-generation pedigree chart. There is no family history of TB contact in the TB contact, and no other family members have a similar illness. Antenatal history, it was a booked pregnancy. Mother received 2 doses of tetanus toxoid. Folic acid supplementations were taken. Antenatal scans were normal. Mother had hepatitis B during delivery, for which medication was given to the child after birth. Birth history, the child was born at term via vaginal delivery at the institution. Birth weight was 1,750 grams. The child was low birth weight. She was observed in nursery for 24 hours and then shifted to the mother's side. This is a 24-hour recall for nutritional history. There was a calorie deficit of 51%. The expected intake was 1,300 kilocalories, and she was actually taking 636 kilocalories, and the total protein deficit was 15%. The child was immunized at a government setup as per national immunization schedule. Socioeconomic history, she belonged to upper middle class, lives in a Paka house, in a 2-room house with clean water supply, and there was no history of overcrowding. Physical examination. The child's weight was 16 kgs, which was according to the IP growth chart. It was less than third centile. Height was 120 centimeters, which was between 10th and 25th centile.
Can we stop at the history?
Yes,
Let's
sir.
stop at the history, okay? Let's
Okay.
first stop at the history, and so that we have the. I'm sorry, I did not. I forgot to introduce Dr. Anurag Agarwal. Dr. Anurag Agarwal is the professor of pediatrics at Maulana Azad Medical College. He has been actively involved in various academic activities in different capacities. Everybody knows him around in Delhi and all of the country. He is a very nice teacher. So I would really love to have the comments from him. So would you like to? I have asked him specifically to stop. So what are the lacunae in the history she has? Okay. Is Dr. Agarwal, are you there? Okay, so now let's come back to the history. So you have the history of fever and cough for 15 days. And this has been more or less like this is a moderate grade, high grade fever. And then it has been, and the cough has been for about wet cough. Huh? Is it
Yes.
productive cough?
Yes, sir.
What is the type of the sputum? It is a purulent sputum. It is in just the mucoid sputum.
Sir, she was not able to spit the sputum out. The child would swallow it. So,
Okay, so we don't know the what was, but then how do we say that this is a wet sputum, wet cough? So she is able to get out some. A 10-year-old should be able to get out some sputum.
uh,
So I
sir,
would expect you know it's not an infant or a 2-year-old who will swallow her his or her sputum. So they should be quite good enough, have a good cough reflex, and to get out the sputum. So I think we need to make these things clear what type of sputum it is. What was the color of the sputum? Was it turbid? Was it purulent, mucopurulent? That might give an underlying etiology of the disease. Okay, and as you had said, the fever, can we define what is mild fever, what is moderate fever, what is high grade fever?
yes, sir. Sir, according to Harrison, we can divide into mild, moderate, and high grade. Mild would be 99.6 to 100.4. Moderate would be 100.4 to 102.2, and high grade is 102.4 to 105.8, sir.
Okay, so 102 to 104, 105 would be a high grade fever.
Yes,
Okay,
sir. Yes, sir.
and above 105 would be hyperthermia.
Hyperplane. Yes, sir.
Fine. So this is a classification for your fever. It would ideally be better to do it in the centigrade. So if you have, say, from 37 point,
Recording in progress. Progress.
sorry. So you have the now. Just give me a minute. I'll stop one of the. Give me a minute. I'll stop one of the. Give me a minute. I'll stop one of the.
Hello.
Hello, yes, sir.
Okay. I think Dr. Dinesh Kaul is logged out or something. He's also traveling. I was also traveling. So I've just reached home. So you have a child who was all right 15 days back and man had. What is the meaning of insidious in onset?
Uh, sir, it was sir, it can be sudden in onset or insidious in onset. So it was slowly increasing, sir.
Yeah, but you have written high grade. So when there is a 15-day fever, either it was starting off with say 100, maybe for 2, 3 days, then 101, maybe for next 2, 3 days, then maybe 102. So you feel that is the character of the fever, or it was simply on day one it was 104.
No, sir, it was gradually increasing, sir.
Okay, so I think you can remove this high grade incidence and onset, gradually increasing to 104 degrees, intermittent, associated with chills. Mm, so this is a 8-year-old child, na?
8 years old, yes, sir.
So 8-year-old child can tell you about rigors also. So with chills, without rigors, although it doesn't make much of a difference. What is the cause of chills?
Sir, release of toxin into the bloodstream, sir. It is.
Okay. Any other cause?
Sir, fever with chills generally, most commonly, we'll see in urinary tract infections, infections like malaria, in sepsis, sir, we'll see fever with chills.
Okay. So why do you have chills and rigor?
Sir,
What he wants to, what's the pathogenesis? What's the pathogenesis of the chills and rigors? That's what he
mostly when
wants.
we are talking about chills, we would suspect bacterial pathology.
No, what happens? What substances are being produced by the body in response to different pyrogens? Okay, so you have certain endotoxins, you have certain bacterial lipopolysaccharide moieties of bacterial antigens. They act as pyrogens, and they will affect the thermoregulatory center. Okay, and then subsequently they will change the temperature setting, lead to fever, and as a cascade the hematopoietic system will produce a lot of interleukins and TNF alpha. That's what he wants to extract from you. What is the, how does the fever occur?
I think sir has got the point. So you have to know the mechanism. Why is there chills? Why is there rigor? Why does the fever go to 104? What does paracetamol do? Should it touch the baseline or not? If it does not touch the baseline, what is the problem? If it touches the baseline, what is your differential? So all this has to be understood very clearly as a pediatrician because we cannot go on investigating everything, na?
Yes, sir.
So chalo, आगे चलो. So now let us look at the cough. What is the cause of wet cough? You said wet cough. Is it specific to something?
So generally, we'll see in viral, we would have a sputum production which is mucoid in nature, and generally when we have a purulent cough, then we would think about a bacterial etiology.
I think you have used the term wet cough with the khadkhad in the chest. Is that what you mean?
No, sir. So they said that so
You will
when
have dry cough or a productive cough. For an
yes, sir.
adult, you will have either a dry cough, say, if you have a dry hacking cough, even in children, bigger children, if you have, say, 10-year-old, 8-year-old having a dry, persistent cough for about 15 days, 20 days, okay, there is no sputum production, irritating cough. You might even think of a mycoplasmal pneumonia
Yeah,
as one.
I wanted to
most of
ask sir, what is the DD of dry hacking cough? Sir ने answer दे दिया. Hmm. So yes, sir is very right. So you have a dry hacking cough, it is mycoplasma or maybe chlamydia, usually mycoplasma, and you have a wet cough. Then what is the differential?
Sir, in wet cough, we would think about Streptococcus pneumoniae or H influenza or sir, Staphylococcus aureus.
Okay, so if the
Okay.
child is sick looking, toxic, you think there is an underlying necrotizing pneumonia and it has led to, then only you will get an sort of an productive cough which would be purulent. Or there is a pneumonia which has led from an stage of red hepatization, gray hepatization into a resolution phase. Then the sputum would be productive type of and with an purulent cough. Okay, so
Yes.
that's what you can see. But for an infant, if you see a chest who is having a lot of rales or crepitations, they are not bringing out the cough, but you are seeing, as you see in bronchiolitis,
Yes, sir. Bees and
so
crackers. Sir.
their cough is a little different. It's a wheezy type of one. You see that they are wheezing. 1 year, 2 year old children who have RSV infection or viral infections, they are the moment they enter, they're happy looking children. But if you auscultate them, they have bilateral wheeze or they have creps. Okay,
Yes, sir.
that would be one type of that would be also wet cough, but they are not bringing it out, they are swallowing it. Okay, so you need
Yes.
to differentiate what is wet cough and what is dry cough. Okay, go ahead.
So this was the negative history. There was no history of any weight loss or night sweats, lumps, any headache, sore throat, earache, discharge, abdominal pain, loose stools, or vomiting. There was no history of intake of unpasteurized milk or any pets at home or travel. There was no
What is lumps? Lumps? Lymph node you're
any
talking about?
yes, sir, lymph nodes, sir.
Okay. Chalo, we usually do not call them lumps or something. Hmm. ठीक है. Why do you want to talk about unpasteurized milk?
So any brucellosis, sir, there would be
Okay,
intake of
chalo, good, good, good.
unpasteurized milk intake.
And then you'll have to add cheese also with it because that is also made from unpasteurized milk.
Yes,
Chalo,
sir.
ठीक है. Okay, pets.
Sir, pets again, any exposure to pets could have led to allergies.
एलर्जी में फीवर नहीं होगा ना 15 दिन का.
हाँ जी, sir. Sir, it can also lead to
What do dog feces cause? Do they cause some disease? Dogs too. Have you heard of toxocariasis?
yes, sir, toxocariasis, sir.
So toxocariasis canis and toxocariasis catis. So there the dog feces will have the larva and that is ingested. So the children might get toxocariasis. They may get a Loeffler's type of pneumonia. So they will have fever and they will have cough, but that will be more or less dry cough. And they may be having, they may present like asthma type of picture with a wheeze. So that's the manifestation of a Loeffler's pneumonia. So then it would be pertinent to ask about the history of pets. And if they have pets coming into the home, they are cuddling the pets, they are holding the pets. Okay,
Yes,
go
sir.
ahead.
So basically, what we want to say is that whatever history you include in negative history, you should have a reason for it. Simple.
Yes, sir.
है ना? You should have a reason for it. कि I thought of this, so I asked for this. Simple, straight. है ना?
Yes, sir.
चलो.
There was no history of swelling on the face or feet. There was no chest pain, difficulty breathing, noisy breathing, chest tightness, cyanosis, or fast breathing. So these were for complications of any respiratory tract infections.
Okay, severity you can find out from this. चलो.
Yes, yes, sir.
Next, continue.
Yes, sir. There was no history of any previous similar episodes or any recurrent respiratory infections, or and the child is not a known asthmatic, sir.
Okay, great.
There's no, this is the 3-generation pedigree chart. There is no Cox contact in the family, and no other family members had a similar illness previous to this.
ठीक है.
It was a
I would interrupt you here because these days there's a lot of emphasis on genetics. So you should be knowing these, what are these squares and dots, and how the abortion is denoted, how the autosomal recessive, autosomal dominant, or sex-linked recessives are connoted in the pedigree charts. So that's very important, because in the DNB OSCEs they ask you a lot of these genetics. So most of the clinical methods textbooks have these newer pedigree charts, so the connotations are there. So I would request you to go through these pedigree charts. Okay, go ahead.
It was a booked pregnancy. The mother had received 2 doses of tetanus toxoid, and folic acid supplementations were taken. Antenatal scans were normal. Mother had hepatitis B during delivery, for which medication was given to the child after birth. Child was born at term. It was an institutional delivery, a normal vaginal delivery. Birth weight was 1,750 grams. The child was low birth weight. She was observed in nursery for 24 hours and then shifted to the mother's side. This was the nutritional history according to the 24-hour recall method. This was the diet. Total calorie deficit was 51%.
So how much calories does मतलब 100 ml of milk have?
Sir, you'll have 73 kilocalories, sir.
Okay, so half glass तो आपने अच्छा हाफ रोटी भी है साथ में.
हाँ जी सर.
चलो. Okay, then it's all right. Roti does not
Roti,
have
sir.
much of protein. How much does a half glass of milk have
Sir, 2
in
grams,
protein?
sir. 2 grams, sir.
2 grams. 100 ml of milk has 2 grams protein.
What
100
will be
ml of milk में कितना?
This is cows or primarily
Cow
buffalo
milk,
milk?
sir.
Huh? This is
Cows is around 3.2 grams. Human is 1.1, and buffalo is also around same, but the calorie is different. So half glass means 100 ml of milk, I believe,
Yes, sir.
Yeah.
at least. So the protein of roti you have missed out in this calculation.
Oh.
And it must be, if it is cow's milk, if it is toned, maybe then the protein content is less. So that protein, I think, remains the same. The calorie content or the fat content falls. Isn't it
Yes,
so?
sir. Yes, sir.
The ICMR chart.
Toned will decrease the fat content, sir.
Not the protein. Protein remains nearly the same because
they
this is
take
what
out
I
the
remember. I would
malai.
look.
They take out the malai from the milk, full cream milk, and it becomes skim milk.
हाँ. So चलो ठीक है. Oh, चलो, that's all right. If you have displayed the table, so I just looked at the contents. Otherwise, we hardly bother. Next.
Sir, the expected calorie intake for this child was 1,300 kilocalories, and the actual calorie intake was 636 kilocalories.
Mhm. So this is the standard picture. Usually there is calorie deficit, but protein deficit is not found. So you got 15%. If you add a little bit of milk, extra protein, you'll find it is nearly all right. But yes, calorie deficit is there.
Calorie deficit of there, sir.
Sure. Next.
She was immunized at a government setup according to national immunization schedule. Belonged to upper middle class, lives in a pakka house in a 2-room house with a clean water supply, and there was no history of overcrowding. Anthropometry, the child's weight was 16 kilograms. Sir, when we plotted it on the IAP growth charts, it was less than the 3rd centile weight for age. Height was 120 centimeters. Plotted on IAP growth charts, it was between 10th and 25th centile. Body mass index was 11 kgs per meter square, which was less than 3rd centile, and weight for height was between 0 and -2 standard deviations, according to the WHO chart. So interpretation was moderate undernutrition according to the IAP classification, sir.
So a good way of writing is you simply write the expected weight, the observed weight, and then the centile. So you can write the expected weight also. Make it just a simple table out
24.
of it.
Yes, sir.
I understand you have seen it. Just
Yes,
mention it because otherwise you'll not be able to get the percentiles.
yes, sir.
That's why
Okay.
we need to say
So-
mention at least the 50th centile. So you have the
Mm.
graphs, you have the chart. So you need to mention that gives you a visual sort of an impression
Yeah.
where the child falls. So if he is this is a 8-year-old child, 8-year-old child.
Yes, sir. 8-year-old child, sir.
So I would expect a weight of around 25 kgs. And what's her weight?
So 16
16.
kgs, sir.
16. So definitely. So that's below the around the third centile. Okay. So what is the 50th centile on your chart?
So 24, sir. It is.
24 from the
Hmm.
IAP. Okay.
Yes, sir.
What is the formula for calculating if you don't have these charts? So do you remember the formula for calculating the weight and the height? For height, you can do from 2 to 12 years. You have the formula. Okay.
Sir, height, age into 6
Yes.
plus
Plus.
77, sir. It is.
Yeah.
We'll
Perfect.
get it in
Perfect.
That will
centimeters.
give you the height.
Centimeter. Height in
Huh.
centimeters, sir.
Correspond
Yes.
to 50th centile.
Yes,
And
sir.
what is the weight formula?
Sir, weeks formula is there, sir,
Weeks
and
formula. Okay.
this child is 8 years old, sir, so that would be age into 7 minus 5 by 2.
Minus. Yeah, I think it more or less looks okay. Yeah, I think that's it.
Or age into 3 also. Therefore,
Yeah, into 3 plus 3. So multiple formulas are there. You can use any.
yes,
This
yes.
is your approximation. Person like sir will remember because after 25, 30 years of practice, you practically know what is the expected weight. 10 years weight is 30 kgs. Simple way to remember. So, chalo, all right. Let's move ahead.
Yes, sir. Is the BMI.
The idea is that you stick to, if you have to plot the growth of this child, so whatever chart you are using, you should be plotting them on the same growth chart. So it is not that one day you will decide I will use a CDC chart, the other day after 6 months you will plot it on the IAP chart. So your plotting of weight and height in a sort of an prospective manner has to be on the same chart. That's the message. Okay. Because these percentile charts do differ little bit in their weight and height because of the ethnicity. Okay.
Yes,
But
sir.
if you are doing on a particular chart, it should be subsequently plotted on the same chart. Okay, go ahead.
Yes, sir. General examination, the child was conscious, lying in supine position, thin build. There was no pallor, icterus, clubbing, cyanosis, lymphadenopathy, or edema. After taking consent from the child and the mother, the examination was done. Vitals versus heart rate was 90 beats per minute, regular, good in volume, all peripheral
What
pulses.
will you do before physical examination?
So we'll take consent, sir, and we'll explain the
take it,
reason for the examination,
Okay.
and we'll
So
proceed.
you would see that this child is and the mother are in a good atmosphere, which is preferably in a sort of in a setup which is sort of congenial both for the mother and the child or for the examinee also. Second thing is that you will wash your hands with soap and water before you touch the child. So preferably if there is a sanitizer, so you would make sure that your hands are clean before you touch the child. Because after COVID, things have changed quite a lot. Now the general public also knows that how patients are to be handled. Okay. So I think we make an effort that at least our hands are clean. We wash our hands before we examine the child. And once we are done after examining the child. Okay, go ahead.
Yes, sir. Heart rate was 90 beats per minute, regular, good in volume. All peripheral pulses were palpable. Blood pressure was 100 by 60 millimeters of mercury, measured in the right arm via auscultatory method, which was lying between the 50th and the 90th centile according to the age and height of the child. Respiratory rate was 24 breaths per minute. Abdominothoracic breathing was there. Saturation was 98% on in room air, and the child was afebrile. Head to toe examination was normal, sir. Eyes were normal. The nose and the nasal cavity was normal. Oral cavity was normal. Neck was normal. BCG was present in the left arm. Chest and abdomen were normal. Back was normal, and limbs were also normal. Respiratory system on inspection, the trachea was in the midline. Apical impulse was not visible. Bilateral chest movements were symmetrical. There were no visible pulsations, sinuses, scars, or dilated veins. There was no tachypnea. Respiratory rate was 24 breaths per minute, and there were no signs of increased effort of breathing. On palpation, the position of the trachea was confirmed. Chest expansion was symmetrical on both sides, and the transverse diameter was more than the AP diameter. On auscultation, there were no crepitations. The 9 zones were examined. Breath sounds were decreased in the supraclavicular, infraclavicular, and the axillary areas. Vocal resonance was checked. Vocal resonance was also decreased in the infraclavicular and the axillary regions. Vocal fremitus was normal. Percussion, on percussion, the infraclavicular and the axillary areas were dull on percussion. Sir, rest of the system examination was normal, sir. On abdominal examination, the abdomen was soft, it was non-tender and non-distended. There was no hepatosplenomegaly. Cardiovascular system was normal, sir. S1 and S2 were auscultated, and there were no added murmurs, and CNS examination was normal, sir. So, to summarize my case, it was a 8-year-old female who presented with complaints of fever for 15 days and cough for 8 days. Antenatal history was normal. Child had low birth weight, and postnatal and family history were not significant. On general examination, child had severe undernutrition, and respiratory examination revealed reduced breath sounds on in the right supraclavicular, infraclavicular, and the axillary areas. So after the history and the examination, the diagnosis was possible diagnosis was right upper lobe pneumonia with collapse, with possible etiology being bacterial. It could be mycobacterium tuberculosis, streptococcal pneumonia.
No, we'll discuss it. Etiology. You can just first let's figure it out. What is our clinical diagnosis and what is our differential diagnosis? First, let's come back to our chest examination. So, because it looks like it is primarily a respiratory system which is being involved. So maybe Dr. Onrag can highlight you the points which you have missed from the chest, and how do you make to differentiate between consolidation, the collapse, the effusion. So how do we go about it? So,
sir, please continue, sir. Please continue.
No, go ahead. I just wanted to, because you are in we work now in a different fashion than, because as the clinical examination is concerned, they should know very how to differentiate between these 3 conditions. So if I say, well, this is a collapse, or this is a consolidation, or this is a effusion, this is what they need to know. Go ahead, Dr. Radhika. So how will you go again onto the respiratory system examination? So what was the, first of all, your respiratory rate? Was the child tachypnic?
No, sir, the child was not tachypnic. The child's respiratory rate was 24 breaths per minute, sir, abdominothoracic, and there were no
24
signs.
breaths per minute.
Yes, sir.
So I think first of all, you can tell us the difference, clinical difference in clinical findings between consolidation and collapse.
Yes,
Yeah.
sir.
What clinical findings point towards consolidation? What points towards collapse, basically?
Sir,
And what points towards fluid or something like pleural effusion or empyema?
sir, on inspection, sir, in a collapse, the trachea could be dilated towards the side of the collapse,
Deviated.
deviated towards the side of the collapse. In
Your trachea is
consolidation,
midline,
yes, sir, the trachea was in midline in this patient,
so
sir.
you are saying collapse.
Yes, sir. Like based on other findings, sir, I was saying collapse, sir.
Okay, continue.
Sir, apart from that, in effusion, sir, the chest movements might not be symmetrical. The chest movements might be decreased on the side of consolidation or collapse.
Okay, that's
And
fine. Go ahead.
Yeah,
sir,
go ahead.
yes, sir. Then, sir, on auscultation, sir, effusion usually will be present on the dependent areas, sir, so on the lower zones. Over here, we have findings that are present on the upper zone. So, effusion is less likely, sir, when there are no findings in the intraaxillary, the intramammary areas, or the intrascapular areas.
What is the percussion note with the consolidation vis-a-vis the effusion?
Sir, on percussion, in effusion, it would be dull.
Is
It
dull.
is
And
typically
what happens
described as stony dull.
Stony dullness,
है
yes,
ना?
sir.
So
So
with
Stony
the,
dullness.
you have to percuss at least 20-30 patients of each type to find out the difference between stony dull and simply dull.
Yes, sir.
You understand?
Yes, sir.
Multiple patients are needed. Maybe you people can go to the adult ward because nowadays it is a bit difficult to get such big effusions in pediatrics. So just see how effusion appears on percussion. It's very important to label something clinically correctly. Otherwise, you have investigations, definitely, yes. But at least we should know what to order and what direction are we pointing towards. Okay?
Yes, sir.
so if you have a massive effusion, it will give a very stony dull. You can very well make it out. No, this is a little over the whole lung. It is involved. If you would just percuss of the whole back, say for this is an big child, this is more than 5-year-old or between 5 and 10-year or more than 5-year, you will be able to examine him like an adult. So there's no problem. So you can percuss all the areas of the lung. This is not an infant where the methodology would be a little different. You will have to rely more on the auscultatory findings. So that's the difference. But what happens, say, as we said, if the trachea is pulled to one side, you might think there is a fibrosis sometimes within either there is a if there's a, say, the right upper zone had this child, if this is a collapse consolidation with a long standing, if there is a fibrosis, so it will pull the trachea towards that side. Okay. But had there been effusion, it would push the trachea towards the other side.
Yes,
So
sir.
that's how you would different. So you would put your finger in the middle, insinuate your both fingers on the other side and see what is the position of the trachea. So that would be then you would see also the tracheal, if you auscultate on the trachea and then go down on the left and the right side, children have normally harsh bronchovesicular breath sounds. Okay.
Yes, sir.
So they are a little different than the adult breath sounds. So you need to really tune your ears to see we missed a bronchial breathing in the right, say, supraclavicular or inframammary region. So if you are thinking that this is a consolidation, so have I missed a bronchial breathing? So listen very carefully that if there has to be some amount of an patency of the bronchi and there is a surrounding consolidation, there may be some bronchial breathing. Okay. So
Yes.
unless and until it's a complete collapse. So if it is a complete collapse segment, then yes, you will not get any bronchial breathing in that area. It seems that if you are not getting any bronchial breathing, you are getting a dull percussion note. And what about the vocal resonance and vocal fremitus?
Sir, vocal resonance, sir, was also decreased in the infraclavicular and the axillary areas, sir.
Vocal both vocal fremitus, vocal resonance were
Sir,
decreased, not increased.
no, sir, not increased, sir. It was decreased, sir.
So what does it favor? Does it favor consolidation or collapse then?
So it favors collapse, sir.
Collapse, yeah. Then if you are telling me the vocal resonance and vocal fremitus was decreased, so then it favor. But because if there's a consolidation,
It would be increased, sir.
it would be increased.
Mm.
Yeah. So, definitely yes. So, if you examine the child well, you can find out from from your clinical examination what you will be getting on an X-ray instead of going the other way around, seeing the X-ray and then looking for findings. I think we can go on, continue.
Go ahead.
Sir, on percussion, also I was getting a dull note in the infraclavicular and the axillary areas.
Okay, fine. So you are getting a dull
Yes,
note.
sir.
So that means there are no areas of sort of an air bronchogram I would see on the chest X-ray, which you can, because the whole thing you are telling me is a dull, and
Yes,
then
sir, dull.
your vocal resonance and vocal fremitus is decreased. Okay,
Yes, sir.
so that supports your more or less a type of a collapse than of a consolidation. So only then a chest X-ray will substantiate your findings, clinical findings. Okay, but you are having fever also at the same time. Okay, most of the time whenever you are having an collapse, so with fever you are bound to have more or less a consolidation, unless until this is a bronchiolitis. A child who has an airway mucus plug is obliterating the rest of the bronchioles, and you are getting a segmental collapse. Okay, you see a lot of times a segmental collapse in one of the upper lobes or one of the segments where you need to do a bronchoscopy to open that up. Okay, so that's what you see quite often in infants. So you will have to attune your ears to differentiate between consolidation, collapse, and effusion. So these are very three entities which you should train yourself, because unfortunately we have also lost the skills, the clinical skills. We are more relying on the imaging, but it is definitely a part of a teaching program for you. So that's what you are expected. They may ask you these things in the exam. Go ahead.
Sir, rest of the system examination had no findings, sir.
Okay. In the abdominal examination, we need to mention also about the bowel sounds. So very
Yes.
important, bowel sounds are present or absent. So if there's a distended abdomen, you need to check the abdominal girth. You need to have the bowel sounds. You need to count the number of bowel sounds you are seeing in a minute. So you have already mentioned about the cardiovascular examination, about the CNS also. You can be little bit little elaborate that the child is conscious. There is no about the motor, about the sensory system. Give a little bit description about these if you have time. And then now you have you are telling about the summary, and you think that this is a right upper lobe. Now it won't be a pneumonia from your clinical findings. From your clinical findings, it looks more of a collapse, right upper zone collapse. Well, fine, if there's a fever, then you may say pneumonia with collapse, consolidation collapse, because they go hand in hand, sync.
Yeah.
And then is the the etiological diagnosis. That's a different thing. Etiological diagnosis. How do you dissect out this? If this child has a collapse consolidation, what could be the likely cause? So what do you
Yeah.
think would be the
So the
likely
best, what sir is saying is very correct. Best way is right upper lobe collapse consolidation, and then you continue with your etiological. Because pneumonia as such is more of a clinical diagnosis. What physical finding you are getting is that of a collapse consolidation.
Yes, sir.
So
So
that
yeah,
will
it
be
could be
once you
a
have the investigations done, everything is done, you have the X-ray done. So if your X-ray is showing some cavitation, areas of breakdown, okay, so your etiological diagnosis will change. If it's an homogeneous consolidation, okay, but
Yes,
if you're
sir.
having you are having a collapse consolidation, if it is a cavitatory thing, then it would be a cavitatory pneumonia. You might think, well, could it be a staph
Yes, all of
pneumonia?
us. Mm.
Okay.
Yes, sir.
So
okay.
adenoviral would have a bilateral type of an
Yeah.
involvement, not a unilateral segmental involvement. So as your findings say, it is in right upper lobe involvement. So we can't really say that what virus is there in no viral. Yes, if the child is sick looking, has fever, has conjunctivitis, has cough, has pneumonia, you are having crepitations in bilateral chest, you might say, yeah, it may be an adenoviral type of an infection. Otherwise, it's very
But
difficult to say
why did
clinically.
you go with only adenovirus? Why not influenza,
Yeah,
flu, or
the
why
season
not
is of flu.
rhinovirus?
Yes,
Yeah,
sir.
the present season is more of RSV and flu is ending
Flu
and RSV
virus.
has begun,
Yeah.
and it is more we are getting is RSV nowadays. Sorry, rhinovirus nowadays. A few cases of Boca also. So simple viral. Don't mention the virus because adenovirus specifically. If you are saying, you have to tell us the reason why adeno. Why not others?
So you're not having any conjunctivitis. You're not
No,
having. So
sir.
you have to have certain valid points for putting it as an
Yeah.
adenoviral infection.
In
Okay.
fact, I got a paper from Bangladesh where they have studied the etiology of around 4,000 viral infections. And to this, again, I've asked them the same question that were you able to differentiate between the viruses clinically, or it is simply a NPS diagnosis, nasopharyngeal swab diagnosis? So they are also not able to say clinically, okay, this is adenovirus has this thing more, or something, the other viruses had that kind of presentation more. So simple
Yes.
viral pneumonia. But
Yes,
it is does not appear like viral because the findings do not match viral. It will be a bilateral kind of a finding if it is a viral picture.
yes. Mm.
Okay. Go ahead. Go ahead. So how will you now approach this child? What would you like to do? The first thing. Obviously,
Sir,
the labs are there.
sir, because the child has presented to us with 2 weeks of uh, fever and cough, sir.
Okay.
So the first thing we would like to do would be an X-ray, chest X-ray, sir.
Okay. So what?
What I missed in your history was that did he not have any treatment history? A child coming to your
Yeah.
setup, not taking any treatment for last 15 days for fever, is that possible? सरकारी में तो
Sir,
कभी कभी आ जाते हैं वो भी बंगाली डॉक्टर से कोई तो दवाई लेके आते हैं.
Yeah,
sir,
he must have got something. We don't have, I'm sorry, we don't have some treatment history. Did he take some antibiotics? Did he some
You
cough
should have mentioned
syrups?
what all treatment he took in your history itself. Went to a local practitioner for fever, was given paracetamol. Something must have been given. You cannot have a child of 15 days fever not taking anything.
the augmentin was taken, sir, for
So you should have mentioned that in your history, no? Because that is a part of history,
yes, sir.
treatment history. The child took some medications, and if he knows the name, well, augmentin, and there was no response, or there was partial response, or whatever happened. In doses which were adequate, inadequate, whatever. If he's taking, say, syrup augmentin 1 TSFBD, which is a very inadequate dose, so you have to mention that.
Yes.
Chalo, आगे चलो.
Sir, these were the investigations that were done. Sir, total leukocyte count was 14,920 with a differential of polymorphs was
In
74%.
case you get an X-ray chest, sorry for interruption. In case you get a chest X-ray, you are thinking of an had collapsed with consolidation clinically.
Yes, sir.
Will just a PA, if I get a lateral view in addition to the PA view, would that have helped you out? I would have got a lateral view also along with the PA view. Okay, so that
Mhm.
would have just defined the anatomical lobe for me. So that would have been more reliable just to give one view than to jumping to a CT scan that would help me know what lobe is really involved. Okay, so
Yes,
you
sir.
can get in this scenario a lateral view also in addition to the chest PA view. Okay, go ahead. So these are your
What is
investigations, routine bloods, and what you have done next.
what
Sir,
is DF?
Direct
direct
fluorescent.
fluorescence, sir. Sorry, sir.
What is that?
Direct fluorescence.
Direct fluorescent. These days,
Oh,
most of the microbiology labs are using as a for detecting the Zeal-Nelson stain. They are using direct fluorescent stains. So direct, it's an immunofluorescent stain. It's a little more, rather more highly sensitive than doing an Zn stain. Though you need to have an immunofluorescent microscope for doing a direct fluorescent stain. So it's a little,
okay.
obviously it's a costly, but this is the where the yield is better of AFB.
So is it better than Gene Expert or
No, it
similar
is
to or
not
No,
better
better?
sir.
than Gene Expert. Gene Expert is definitely far better than doing, and it will pick up even if you have few bacilli, it will pick up. But for an say for an direct fluorescent stain, you might need so at least 100 viable bacilli per high power field. But for an say for an same for an detecting on the Zn stain, you might need around 10,000 bacilli per
Yeah,
micro
5,000 bacilli per high power field is
per
for
yes.
Zn,
So then only
and Gene
you can
Expert
make
is
it out.
130 around bacilli per
With DF
ml or
stain is
something. Gene
quite
Expert.
sensitive. You can pick
Okay,
up 1 plus DF stain. If you have 1 plus DF stain, your sometimes
it's
Zn
positive.
stains are negative. So that's the only,
Okay.
but only thing is it is more costlier
It is
than
not
doing it.
part of the program also, no?
No,
The
it's not a part
NTP
of the program.
program.
No, it's not part
Yeah.
of the program. They are doing in this CB-NAT primarily. Yeah.
Yeah, CBNAT. So I think instead of writing Gene Expert, you should write just
Yeah, you
simply
can
CBNAT.
write in, it's in, these are all, instead of Gene Expert, you can write in CB-NAT.
Yeah,
That
CBNAT.
may be, or in PCRB. They are all
RT-PCR,
molecular
the real-time
hybridization technique.
PCR. चलो ठीक है. So Gene Expert was negative, and
Sir,
sputum and gastric aspirate both were negative. So you did both of them. Chalo, good. You can
sir,
afford to in private. In government,
induced
we only send G.
sputum was
Uh,
not coming, so we had to induce it, sir. But still, it was negative, so we went ahead with the gastric aspirate.
okay, okay. चलो ठीक है.
Do you think that, say, your sputum is negative? Do you think that with an 8-year-old child, a gastric aspirate would have a better yield?
Sir, the mother said that she was swallowing her sputum, so
Okay,
that is
you
the
thought,
reason
okay,
we went ahead with
you thought that you could get the yield from a gastric aspirate.
gastric aspirate.
Okay,
Yes, sir.
fine. Go ahead. Okay.
So this was the chest X-ray that was done,
So
sir.
what does it show now? Now let's can you comment on the chest X-ray?
Yes, sir. So this is an X-ray of chest, posterior anterior view, where trachea is in the midline, sir. The cardiac thoracic ratio is normal, and in the right upper lobe, a collapse can a homogeneous opacity can be seen in the right upper zone, suggesting of a collapse.
Yeah.
Okay.
And the left is compensatory. So the lower lobe is compensatorily being pushed up.
Yes, sir.
Uh, so
Lung
that's the
volume
middle
is.
lobe, in fact. Yeah.
Mhm.
So I think yes. Anything else?
Can you see any air bronchogram in the within the
You
opacity?
you moved it. Yeah.
So it's if
So
you
look at the
try
air
to zoom
bronchogram.
it, you don't see any evidence of any cavitation or any breakdown. Okay, so had it been a cavitation or a breakdown, at least I can't see on this chest X-ray. It seems it's an homogeneous. It's more of a
Homogeneous.
collapse.
Mhm.
It's a segmental collapse. You can see a typical curvilinear shadow
Sharp borders.
in the right upper zone. Okay,
Yes, sir.
trachea is central.
Yes, sir.
Okay, is there claustrophrenic, cardiophrenic angles are okay? So you need to comment the claustrophrenic about the effusion. They are okay. There's
Yes, sir.
nothing.
There was no blunting of the claustrophrenic
Right.
angles.
At the same time, you should also look at the bony cage, look at the vertebra. Okay, sometimes you miss port spine. So if you are very careful, you might pick up port thoracic at least here in the chest X-ray only if there is some destruction of vertebrae. So be careful about these. A good radiologist will pick up these findings. Okay, go ahead.
Sir, because our findings so far were negative, we did a bronchoscopy on day 3 of admission, and the bronchoalveolar lavage sample was sent for evaluation, where on the PCR we got mycoplasma pneumonia, and here, sir, the nucleic acid amplification test was positive, and rifampicin resistance was not detected, sir. So after this, the child was started on ATT, sir, 4-drug ATT.
Okay, now you have the, because you thought that there was a underlying segmental collapse. So that's what possibly had this segmental collapse not been there, possibly that was bothering you, and that's why even after a few days of physiotherapy, or if it has not opened up, the chest X-ray has not shown a resolution. So that's why you need to do a bronchoscopy. Okay, so then only in this scenario you would do a bronchoscopy, but obviously for the yield. So here you are fortunate enough that you got a positive yield for the from the gene expert from the nucleic acid amplification test. Okay, but
Yes, sir.
surprising is that you have a mycoplasmal pneumonia also positive. So what is the contribution of the, do you think that this chest X-ray looks like a mycoplasmal pneumonia?
No, sir. In mycoplasma pneumonia, it would be an atypical pneumonia where the child is stable, and there'd be bilateral interstitial infiltrates in mycoplasma. Over here, it would not be a
So you might see a bilateral involvement. Yes, there have been case reports of isolated lobar pneumonia or segmental collapses with mycoplasmal pneumonia, but norm is not it causes more or less an interstitial type of pneumonia. Both the lung fields would be involved.
yes, sir.
Okay, and you would have a mycoplasmal serology would be positive by this time. 15 days of fever, if you get a mycoplasmal serology, mycoplasmal IgM test done,
LI, sir.
possibly you think that yes, he has a mycoplasmal infection, but since your PCR, as it looks like that possibly yes, he may have had a mycoplasmal infection only, but I'll really try to, I mean, it's a little difficult we have to treat it, obviously, since you have got a mycoplasma positive and your IgM mycoplasma, if also comes positive, it's better to treat for the mycoplasma pneumonia. Okay, fine. So you would start this child on ATT?
Yes,
or
sir.
no?
Sir, we would start on 4-drug ATT now, sir, because we have
What else? Did you do a Mantoux? Did you do a skin tuberculin test?
Yes, sir. A skin tuberculin test was done, sir, but there was no induration. So it was
Negative. Though
it was
they have,
negative.
I think they have taken out the Mantoux also in the National Tuberculosis Program to make a diagnosis, if I'm correct.
Yes, sir.
So
Now it's X-ray, and then you see the nucleic acid amplification.
nucleic acid amplification test. So whether you are doing either a gastric lavage, bronchial lavage, or even the nasopharyngeal aspirates, because there is good enough data in smaller children that even if you take nasopharyngeal aspirates, they may show positivity on the nucleic acid amplification tests. So you will start this child on ATT. He has to be notified. Okay, that's a very important thing. These children need to be notified, so that they are not lost to follow up. Okay, fine.
Yeah.
Anything else? Would you like to comment, Dr. Anurag? Anything else?
Sorry, I had logged out. I'd have to log in again because suddenly the Bluetooth stopped working.
Yeah.
What was the discussion? Last 1 minute I missed.
I was just trying to, they had also got a positivity of the mycoplasmal PCR positive. So we are trying to figure it out that does he have a co-infection of a mycoplasma? So we are trying to look for the clinical features of mycoplasma pneumoniae. And I suggested that they should have done a mycoplasma IgM because the radiological picture of mycoplasma would be a bilateral interstitial type of pneumonia. This
Yes,
child
yes,
would have
sir.
dry hacking cough,
Yes, it does not look like a mycoplasma
mycoplasmal,
clinically or
but
from the
yes,
X-ray. And BAL PCR mycoplasma pneumonia positive, I would not be very happy with having two diagnoses for one condition. What was the bronchoscopy findings? Did you get any endobronchial tuberculosis or anything of that
yeah.
sort?
No,
What
sir.
was the? Yeah. There
No,
was
there
no
were no.
tuberculosis.
There were there were no findings, sir, on bronchoscopy. The BAL sample had revealed.
So
Did you get a chest X-ray post bronchoscopy done about few days
yeah.
later?
So was some mucus removed from the bronchus? Because if it's a mucus plug, you remove it, the lung will expand on its own. Nothing
Sir,
of that sort was mentioned.
sir,
Did
the
you get a
bronch.
repeat chest X-ray?
No, sir,
Uh,
we did not do
No.
a repeat X-ray after bronchoscopy, sir.
Yes, I would normally, if see had it been a segmental one of the airways is obliterated, you have this type of an segmental collapse. So I would have got a repeat chest X-ray post bronchoscopy, seen the status of this airway. What has happened to the chest X-ray? That would be a little more cost-effective technique. I would not even do a CT prior to, jumping to the bronchoscopy. Okay. So now you have a child, 8-year-old child with a collapse consolidation, more of an collapse. Okay. You don't have any areas of breakdown on the chest X-ray. Did you get any CT or anything like that?
Sir, CT was done outside, sir, and
Okay.
it showed collapse consolidation in the right upper lobe, sir.
Collapse consolidation. And
Yes, sir.
no
did it have
cavities,
any?
nothing of that sort.
No, sir, no cavities and or
No
any
cavities. This was done prior to coming to the hospital.
prior, sir. Yes, sir.
Prior to coming. So
Okay.
there was no any area of breakdown.
No, sir. No
There was no any
necrotic.
cavitation.
No, sir. No cavitation. No necrotic lymph nodes or
Okay, no,
any.
fine. No
System.
mediastinal lymph
Nothing suggestive
nodes.
of tuberculosis as such. There was no lymphadenopathy or any other feature of tuberculosis.
No, sir. The child was thin built and then it presented with cough and
No history of
fluid.
contact, but that is not necessary because in one of our thesis we just got contact in around 25% of patients. The rest didn't have contact. So
No contact, sir. In this
no
case.
contact history.
Mm.
Okay, so how will you proceed now with this child?
Sir, because now the nucleic acid amplification test was positive, so we started the child on, and there was no rifampicin resistance. So we
Mhm.
went ahead with starting the child on a 4-drug anti-tubercular.
Will you want to send some other investigation also on BAL after
Us,
getting this? Even if you have got MTB detected and rifampicin resistance not detected, we want
so
to
we
send
sent
anything
a
else?
culture, sir. We sent a liquid culture, sir, and
MJIT.
yes, sir. We sent a
So you
culture
have to
to
send MJIT
MJ.
also.
Yes.
Why?
Sir, to get the sense, because sir, sometimes even if rifampicin resistance is not there, we might have isoniazid resistance. So we have to see the drug sensitivity pattern for TB here.
Yeah, because INH resistance is around 7 to 8% in fresh cases and 11 to 20% in retreatment cases.
Yes,
So
sir.
we are looking for INH resistance also.
Yes, sir.
And we will have a double confirmation if it is if it grows Mycobacterium tuberculosis, that yes, we are treating tuberculosis and not Mycoplasma pneumonia.
Yes, sir.
So uh, okay, continue.
So the diagnosis was a microbiologically confirmed case of pulmonary tuberculosis with Mycoplasma pneumonia with right upper lobe collapse consolidation and severe undernutrition, sir.
Initially, you had mentioned something else on undernutrition. ये आप severe हो गया यहाँ पे?
Moderate undernutrition. Sorry.
Okay,
Hmm.
चलो ठीक है. And then
So
yeah,
that's it, sir.
okay. Uh, I think sir, do you want to add anything?
No, that's fine. You need to, for a nutritious point of view, you need to be very specific about, because in your you will have a lot of TM cases. So malnutrition, you will have to grade them. You will have to figure them. Do they have primarily protein allergy malnutrition? What type of the gradation of malnutrition as per the IAP classification? So you should be able to grade the malnutrition. What grade do we have it here?
Sir, moderate grade, sir. So above, sir, we will see the
On the
weight and then
percentile, okay.
ha,
Is it at the was it be grade 1 or grade 2?
so grade 2, it was 66% of ideal body weight.
66%. So it will
Hmm.
be grade 2. So you
Yes, sir.
think that this is grade 2 according to IAP
IP,
classification.
yes, sir.
So somebody might use a WHO classification or anything like this. Anyway, I think we had a wonderful discussion. Thanks a lot to the Dr. Rag. Thanks a lot to, I think I have three questions. Let me figure it out. If somebody has asked a question, can you, Dr. Radhika, just see if anybody has put a question?
Sir, I cannot
Uh,
see any questions.
no
I can't see
questions.
any
I can't
questions.
see
Okay,
any.
there are
Yeah,
no questions.
just no questions.
Okay, fine. Thanks
So
a lot.
we
Then
have.
I think I thank everybody. Thanks for sparing your time, everybody who has been who has participated. But I would request all the postgraduates kindly try to get hold of your other colleagues, because we try to do this exercise every week. So this is meant for you. Thanks a lot. I think
Thank you, sir,
thank,
and
okay.
thank you, Dr. Radhika, for an excellent presentation. We enjoyed it, and it was really up to the mark. Other than that, further questions can be on tuberculosis in your presentation. So it can be on treatment, approach, and all the complications of tuberculosis. But this was really good. Thank you so much.
Thank
Okay.
you, sir.